Let's talk about the dermis. We've already reviewed in a separate video about the epidermis, the most superficial aspect of the skin. Now we're going to talk about the connective tissue layer below it, the dermis. As with most kinds of connective tissue, it is vascular, in this case very richly vascular. Remember that epithelium does not have its own blood supply. It has to get it from the capillary beds immediately deep to its surface. The dermis is also heavily innervated, lots of nerves. Lots of blood vessels. And it's also heavily attended to by the immune system. As this is a connective tissue layer, it's made up of fiber component and a ground substance component, right? The fiber component is going to provide the rigidity and structure to the overall, and the support to the overall layer. The ground substance is, remember, just like a thick fluid. Immune cells can easily work their way through this type of tissue. The dermis is mostly dense irregular connective tissue. You'll find that lots of supporting layers are made up primarily of dense irregular connective tissue. The superficial most aspect up here gets looser, and that's made up of areolar connective tissue. Up here close to the surface, or close to the deep aspect of the epidermis, you need to hang on to more capillary beds and things like that, and so the ratio of ground substance to fibers needs to be a little heavier in the ground substance direction. There's two layers to the dermis: the papillary layer, which is up here, and the reticular layer, which is down here below. Now remember, this is a papillary. I'm misspelling that, P-A-L. Okay. Now remember that connective tissue will have a variety of different fiber types, and it'll be dominated by one type or another. So dense irregular connective tissue, if you recall, is heavily dominated by collagen fibers and going in all sorts of different directions. It's very disorganized looking tissue. There are reticular fibers here that will help support the structure of the skin and provide a scaffolding for it. The papillary layer is this superficial part that's mostly areolar, and it has this wavy edge to it. Whenever you see a wavy edge to something, you're going to think of the word papillary. That's what papillary refers to, are those finger-like bumps that you'll find. The boundary between the epidermis and the dermis is very obvious. I'll show you a slide of that next. But just as it's drawn right here, you can see that boundary quite cleanly. The boundary between the reticular layer and the papillary layer of the dermis is not obvious. It'll transition fairly seamlessly from areolar into dense irregular connective tissue. Things like hair follicles, nail beds, and glands are all ultimately embedded in the dermis, although they emerge through the epidermis. So you can see here, this is a slide of skin with the epidermis and the dermis. Here is your boundary between the epidermis and the dermis. You can see quite clearly you have this first layer of basal cells. Here's your granular layer. Here's your spinosum. And here's your corneum, your stratum corneum, all those thin anucleate. They're filled with keratin, but in this type of slide, the keratin doesn't pick up the dye that everything else is seen with. Now take a look for a moment at the connective tissue of the dermis in particular. You'll notice that down here you see those big, thick collagen bundles characteristic of dense irregular connective tissue. Up here, there's a little bit more variety. What you see here, these guys, that's sort of the edges, profiles of capillaries that are coming and going, so that doesn't really count. But you see lots of little wavy bits coming and going. You see occasionally thicker bundles. You see big gaps from here and there. Clearly, this type of connective tissue up here is different from the connective tissue down here. This slide is nice because it does look like there's sort of a line between the dense irregular reticular layer and the papillary layer. This would be the papillary. And this is the reticular layer. Dense irregular connective tissue. That's my abbreviation. Don't write that on tests. You can see or at least appreciate that there's a bit of a boundary between the two on this slide in particular, but it's oftentimes not so clean. You're going to identify the papillary layer, the areolar connective tissue, mostly by its proximity and orientation against the epidermis, which is all the connective tissue that forms these big finger-like projections and immediately deep to those invaginations of epidermis. Now, we already saw in the last slide that the boundary between the epidermis and the dermis has this sort of wavy, ridgy sort of a nature. But on a three-dimensional structure, those waves build on each other to make, how am I going to do this? Sort of bigger waves even. Like this. You see how there's two sets of waves? There's these waves as well as this wave. So the boundary between the epidermis and the dermis is like ridges on top of ridges. The smallest projections in that ridge upon ridge sort of a formation are papillae, these guys right here. Again, papilla is usually going to be something that's like finger-like or sometimes like this. Those are going to be arranged in larger rows, which are called dermal ridges. So these are papilla. And dermal ridges are the larger ridges that they ride on. These are also known as friction ridges and are most commonly known as fingerprints. Your fingerprints, you can see, if you look very closely to, say, your forefinger, you can see all those little bumps and grooves that make a nice sort of a wave pattern. Inside of each one of those bumps and grooves, you can see more little bumps and grooves if you had a strong enough microscope. That's what we're talking about here with ridges upon ridges. Inside the papilla, you have thick bundles of capillary beds. You can see here. The dermis has its own nerve endings that reside in here. Meissner's corpuscles in particular are very sensitive to light touch. So when you have a tiny insect crawling on you and you don't even necessarily see it, but you can feel that very, 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 very slight touch, your Meissner's corpuscles are picking those up. These, unlike the Merkel cells, which were its own cell that communicates with a nerve ending, these corpuscles are actually encapsulated nerve endings. They're not their own cells. And movement of those nerve endings, physical movement of it from the vibrations of something walking on your skin or any other kind of movement that your skin picks up when something is moving across its surface, is going to open up sodium channels. It's literally like flipping a switch where you have the cell, the nerve ending right here, and when something walks across it and sends vibrations, it can flip the switch to open the sodium channel. We'll go more into what that means, the sodium channel stuff and opening and closing channels by movement or pressure or whatever, when we get to the nervous system. But for the time being, appreciate, please, that the light touch nerve endings are called Meissner's corpuscles, and unlike Merkel cells, they are their own encapsulated nerve endings that when they pick up sensation, they'll physically open and close channels. So going back to those ridges then, the larger ridges, the friction ridges, your fingerprint ridges basically, we use them, we find that they're useful in identifying people. So the hypothesis is that no two people have identical fingerprints. That's a super flawed hypothesis, but that's for a forensics class, not an A&P class. The purpose, though, anatomically or physiologically is different. So the reason that we have them is for two main reasons. First of all, by having this ridged orientation between the epidermis and the dermis, it means that when friction or force is applied in a shearing motion on the epidermis, the whole thing doesn't just slide off. You have little bumps and grooves that it rests in that the epidermis can basically lock into, which is nice. It's a very elegant, simple way of preventing skin slippage. Those larger friction ridges act like treads. So when you look at a tire, for example, you'll notice that the tires on your car are not perfectly smooth. They instead have ridges to them. That increases the surface area of your tire, and so you're able to gain better traction. With your fingers, it's the exact same thing. If your fingers are perfectly smooth, it's going to be harder to pick up small things than it is if you have treads on your fingers, if you have these friction ridges on your fingers. In addition, since you have nerve endings and stuff embedded into the papillae, and therefore embedded richly into the friction ridges as well, when you have motion across the surface and you have vibration or movement or tugging on one of those friction ridges or on one of those papilla, you can pick up sensation that's finer than you might otherwise. If all of your nerve endings were buried all the way down here and you didn't have these papilla, everything was straight through, when you have friction across here, you're not going to be able to make as much contact with any given one of those nerve endings. But embedding them inside, I'm just going to make one up and put it here, inside of a papilla or inside the tip of a friction ridge means that when this thing is tugged, you're going to put more pressure on that nerve ending. So it also improves your sensation overall. Now let's take a look at the reticular layer of the dermis, the deeper of the two dermal layers. This, as we talked about, is made up of dense irregular connective tissue, and it in turn is anchored onto adipose. This is also known as your hypodermis. Remember, this is not part of the integument, and it's also known as sub-Q, or with the letter Q here, short for subcutaneous fat, fat that's under the skin. They're all interchangeable terms. The hypodermis is the preferred term for that layer as a whole. Recall that the hypodermis is made up of primarily white adipose connective tissue. The reticular layer is heavily vascular and contains what's called the cutaneous plexus. Anytime you see plexus, you're going to think a tangle of threads. You hear the word plexus whenever you have a string-like anatomical structure, a blood vessel or a nerve, for example. They all have this sort of a string-like nature to them. And when you have a lot of them coming and going and interweaving with one another and communicating with one another, that's called a plexus. So what this should tell you is that if it's vascular, it's blood vessels. Cutaneous refers to the skin, and plexus is that tangle. So it's a tangle of blood vessels immediately under the skin. This is going to provide a great deal of the blood supply to the epidermis. These are ultimately going to culminate in capillary beds in papillary layer, in the papillae properly, which is immediately deep to the epidermis, immediately deep to the basal layer of the epidermis, and all of the nutrients and fluids and whatnot are going to diffuse through the layers, moving superficially through the epidermis. The reticular layer, being dense irregular connective tissue, the fiber type is mostly collagen. It's mostly made up of collagen. Again, there's going to be some elastic fibers, there's going to be some reticular fibers, but it's predominantly collagen fibers. And these do run in all kinds of different directions individually, but when you zoom out and take sort of a whole body view, you'll notice that they kind of arrange themselves into parallel rows around the body. These rows, when they're adjacent to one another, are bundled fairly loosely, so it does take on a fairly discrete striped appearance. And these are known as Langer's lines, also known as cleavage lines. I still use the word Langer's lines by, frankly, habit. So you'll hear me use that term more often, even though I think cleavage lines is probably the preferred term now. So this diagram right here of the person shows the Langer's lines on your body. And this is showing how the skin is anchored down onto the hypodermis underneath by way of those collagen fibers that are connecting the epidermis to the dermis. So on your back, for example, those collagen fibers are locked down between the epidermis and the dermis and ultimately running in this stripy kind of a direction, diagonal stripy. Around your lower abdomen, they go side to side. Around your arm, they go sideways here. They kind of have a curved appearance in your forearm. They're different in different places in the body, but they all take on some sort of a layered striped pattern. There's a couple of things that make that important. First of all, when you have growth that's perpendicular to your Langer's lines, that's where you get stretch marks. So take a look at your lower abdomen, for example. All of these fibers are kind of in a V formation. If you're pregnant, boom, boom, you're going to stretch out, especially up here isn't going to be as big of a deal, but below, in the lower abdomen, you're going to be stretching those out into a more horizontal shape as you grow outward. This is going to put stress on the collagen that's running mostly in this direction. Your skin's going to be growing faster in between each one of those stripes than it is on the stripes, and you're going to get dark lines. They're like basically scars as your skin grows faster than you can keep it anchored to the skin below it, or to the hypodermis below it. Think surgically now, okay? So when you, how do I want to go about this? So way back when, a surgeon would approach into the patient with whatever incisions were most convenient for the surgeon. The theory is, if you have to get in there, you better make sure that the job is going to be straightforward for the surgeon so that they can do their job most effectively. And if it results in a little extra scarring or healing time, that's fine, because the alternative is they can't see as well and they won't do as good of a job when they're in there. It does make some sense. Since technology has advanced and visualization is better and the techniques are more refined, we've been able to experiment more with different incisions. And what we've found is that in surgery, when we make incisions that are parallel to the Langer's lines, so for example, if you're going to remove somebody's appendix, that's in your lower right quadrant, right? Somewhere in here. So if you make your incision like this, your tissue, when it's sewn back up, will heal much, much more securely because you're creating an incision in the same direction everything's going anyway. You're not slicing a bunch of extra collagen lines that you didn't need to. The suture and the wound healing is going to be faster, more thorough, and it'll scar less. Scar tissue, if you recall from the epidermis lecture, is much weaker than the tissue surrounding it. It's very, very, very disorganized, and so it's just not as strong as the tissue around it. So wherever you can minimize scarring and create a nice, clean, even wound to heal, the better. Before, they might have made the incision like this. Because if you have a surgeon standing here working on there, this way they can get in and see a little bit more easily. But it's perpendicular to those Langer's lines, and so you come up with a much nastier looking scar that also is just weaker and doesn't heal as fast. If you have a wound that has, or if you have a scar on your abdominal cavity, that's an increased risk for herniation in that site for the rest of your life going forward. It's not a great situation to have. C-sections, way back when, they used to just slice you straight up and down and then open up, because that's where your linea alba, that white line between your abdominal muscles is. So they just figured go straight in through the middle the whole way through, and then once in the uterus, open it up long ways, the way it's sort of easiest to get the baby out. That provides a really long, nasty, gnarly looking scar that doesn't heal as well. The risk of uterine rupture is higher, the risk of abdominal wound rupture is higher, the risk of herniation is higher. Nowadays, what they do is they make an incision close to the bikini line that's more like that, and much more closely follows the Langer's lines. And this has two benefits. First of all, it's hidden more because it's down by your pubic hair and can get hidden, frankly, in the future, hidden by your underwear. Second of all, because it's along the Langer's lines, it heals very, very, very nicely. It heals with as little scar tissue as possible. It heals quickly and it heals relatively simply. There's not many complications with it. If you look at your body and you look at scars that you might have, you'll notice that some of the worst ones on most of us. Now, if you have a terrible, super deep injury, it's just going to scar badly no matter what. But if you have, say, a wound like I have from my pet grooming days, I've been scratched by cats a zillion times, and so my forearms, I have all these scratches that go kind of like this. So you notice those are perpendicular to the Langer's lines. My scars that go perpendicular are a lot deeper and have a bit more of a protruded nature to them than the ones that go like this. Those scars, where I even have them at all in the first place, are much less visible. In places where you have less of a hypodermic layer, less fat, you'll find a closer attachment of the reticular layer to the deep fascia underneath. The deep tissue, that fascia, is the covering over your muscles. Okay, it's a connective tissue covering over your muscles. So there's some places where you have so little fat that your reticular layer of your dermis basically connects straight up to bone or muscle or whatever's underneath. Those create what are known as flexure lines. They're just wrinkles where you have joints, where you don't have a lot of fat. So look at your knuckles. You feel your knuckle, there's not a lot of fat there, right? Certainly not compared to the rest of your fingers where you don't have a joint. And when you look at it, you'll see those sideways lines. Those are your flexure lines. The wrinkliness of your elbow. For some of us, the wrinkliness of our knees. Those are flexure lines, and they're where you have a more direct connection between the dermis and the underlying tissue. Let's talk a little bit about sweat glands. These are more properly termed as eccrine glands, and they function by merocrine secretion. These are also known as sudoriferous glands. Sudoriferous refers to a sulfury compound that we do excrete in our sweat. These are the most abundant glands on the body. They're rich on the palms of your hands and the soles of your feet, as well as your face and a little bit on your the middle of your back. They are entirely absent on your areola, on your genitals, and your lips and your external ear canal. These are coiled tubular glands. So you see here is a picture of a sweat gland. Here's a tube that invaginates down through the epidermis and into the dermis. And then down here, you have this sort of coiled appearance. Remember, you have a wavy structure. That's so that you can pack more stuff into a smaller space. You can increase your surface area, in this case, for sweat secretion. The secretory region, the bulb, so if we just super simplify this down, it's sort of like that. It's not really, because this is a big coil at the bottom, but you get the point. Down at the bottom, this is all simple columnar epithelium, which makes some sense, right? Because when we talked about the tissues, we talked about secretion as having a lot to do with columnar epithelium, pseudostratified and simple columnar. In this case, it's simple columnar epithelium. You have, right around it, capillaries, and blood plasma from the capillaries will leak through the into the simple columnar epithelial cells. They'll modify it slightly. They'll take a lot of the solute out so that the sweat is hypotonic, and then they'll secrete it into the lumen. From there, it'll work its way out. Hypotonic. It's also slightly acidic. The tubular portion of the gland is stratified columnar. If you recall, we find stratified columnar on some glands. Okay? The composition of what else you secrete in your sweat. Remember, it's hypotonic, but it does have some solute in it. The composition of that solute is mostly driven by your genes. Now, we have a lot of certain chemicals in common, in particular some sulfur-based compounds that most of us will secrete pretty abundantly in our sweat. But there's quite a bit of variation, and those tend to run in families. That said, there are some compounds that tend to work its way out into people's sweat more easily than some other compounds. Garlic, for example, the smell of garlic can work its way out into your sweat pretty well. The smell of cumin works its way out pretty well. There's a drug called rifampin that's a tuberculosis drug that has a pigment to it, like an orangey pinkish kind of a pigment, and that pigment molecule works its way out in through your eccrine glands pretty well itself. So what will happen is if you're on this drug for a long time, people will start to sweat orange instead of clear. It'll ruin your clothes. They tell you about this before when you start taking the drug. You'll cry orange tears. It's really weird. The main role, as we've discussed before, of sweat is to cool the body. It can also be induced by the sympathetic nervous system. When the sympathetic nervous system kicks in, we'll talk about this later, but it tends to turn everything on. It's not a very selective kind of a system. So your sweat glands tend to get turned on with the rest of those. In addition to being hypotonic and slightly acidic, having a cooling function where it can evaporate pretty easily, this also encourages the growth of your normal microbiome and helps inhibit the growth of pathogens on your skin. There's another kind of sweat gland that's turned on at puberty called your apocrine sweat glands. These are limited to the axillary and anogenital regions, armpits and groin. They're turned on at puberty. The gland itself has a similar coiled tubular structure to regular sweat glands. The cellular arrangement is similar to regular sweat glands, and it has the same composition as regular sweat glands, but it also has extra fats and proteins. It's thought that this has a pheromonal reasoning to it. The reason that we have these special separate glands that turn on at puberty is pheromonal, like subconscious smell mate attracting kind of compounds, but we don't really know. It's uncertain. You're going to read in every textbook in the world that these secretions are yellow and odorless. Now, if you've had an old white t-shirt that you've sweated into a bunch, you'll know that it has a yellow tinge to it around your armpits. That sweat that comes out of your armpits has a yellowish tinge to it. That can get locked into your fabrics by using certain types of antiperspirant, but it's not like the antiperspirant is making that color yellow. It's because it's already a little bit of a yellowish color in the first place. The odorless part is what baffles people because, I mean, armpit sweat doesn't smell like nothing, right? Teenagers don't smell great. The reason that it has this odor to it, the secretion itself is odorless. But since it has all of these extra fats and proteins in it, aka bacteria food, the secretion of this type of secretion encourages bacterial growth and encourages a change in the local microbiome in those areas. So that when you have this increase in bacterial growth and that it's different from the rest of your microbiome a little bit, you're going to smell it a little bit more. You're going to have more bacteria and it's going to smell more strongly. A modified form of apocrine glands are earwax and milk from mammary glands. The glands that secrete earwax are called ceruminous glands. Remember, so cerumen is earwax. Where else have we heard a word that sounds like cerumen? Ceramides, secreted in the granular layer of epidermis. The cerumen that you're ears produce, your earwax, is similar molecularly to the stuff that you make in the granular layer to help sort of waxen up the outside of your epithelial cells. Your mammary glands are also modified apocrine glands, and those secrete milk after a mother has a baby. Your sebaceous glands are also known as oil glands. And these function by holocrine secretion. These glands are lipid-filled, they're rounded, they're not that tubular or wavy tubular form, and they're found everywhere on the body except for the palms of your hand and the soles of your feet. The reason that you don't find them on the palms of your hand and the soles of your feet are because you don't have any hair on the palms of your hand and the soles of your feet. Oil glands, sebaceous glands, are associated with hair follicles. So where you do not have hair, you do not have oil glands. You can see right here, there's an example of there's the oil glands, and then this is part of a hair follicle, and you can even see some of the hair right here. Okay. What these do is you have cells that will accumulate lipids basically until they burst, and then the whole cell and all the oil that it's accumulated, all the cellular debris, all get excreted. The function of this oil is to help coat the hair, help keep it resilient and flexible and protect it. It also secretes onto the surface of the skin, affects the pH of the skin because it's a little bit acidic, and it helps encourage the growth of your normal microbiome and suppress growth of pathogens. So this sebum, as it's called, the oil secretion, is bactericidal to pathogens. Okay? Now, because what you're secreting isn't just the oil, it's also the oil plus cellular debris. What's all that extracellular debris? All those fats, all those proteins that are going to be secreted? Think back to the apocrine gland. Yeah, that's really good bacteria food. And what do we associate with oil glands, particularly on our face? Acne, right? When your oil glands on your face in particular turn on in abundance when you start to hit puberty, they kind of go into overdrive a little bit through those years. You're not just secreting oil, but you're secreting lots and lots of cellular debris. This isn't something that you can inherently change. It's not like drinking a bunch more water is going to thin it out or make it have less debris in it. It's simply going to it just is. You kind of can't help that. The bacteria that are already living on your skin then will feed on that, and when it gets into places it shouldn't, like in towards that oil gland, you can end up with a little mini micro infection, and we think of those as pimples. It doesn't constantly just sort of leak oil onto your hair and onto the surface of your skin. What you have is a little smooth muscle cell attached to each hair follicle called an erector pili. What this will do, and this illustration isn't actually great, it should draw it sort of more like this on top of the oil gland where it sort of traverses that oil gland. The function of an erector pili when it contracts is to pull that hair up straight, goosebump style, right? When it contracts, it pulls on the oil gland and helps secrete that oil out towards the surface. That erector pili muscle, a smooth muscle, involuntary, forces the sebum out. All right, so we were just talking about oil glands. So now we got to talk about the hair follicles that are associated with the oil glands, right? As we just discussed, you have oil glands and therefore hair everywhere on your body except for the palms of your hands, soles of your feet. Also, you have no oil glands on your lips, nipples, and portions of your external genitalia. The fact that you need lip balm constantly should help tell you that that area needs help being moisturized. There's no oil or moisture. There's nothing keeping your moisture in right there. Your body hair, you have hair everywhere on your body. Males and females both, everywhere on your body except for those places otherwise stated. And it's generally super thin and wispy. It's called vellus hair. This is too sparse to have any use anymore. Way back in evolutionary time when we had lots of hair, we also had thinner skin, and that hair helped supplement our ability to keep ourselves warm, and it also served as protection against physical assaults, against UV radiation, against weather. But we've lost a lot of that hair, and in response, our skin has gotten substantially thicker, and we've developed more melanin that can help protect us against UV radiation. Next time, if you ever find yourself going to the vet with your pet, ask them how thick that animal's skin is under all that fur, and they'll usually tell you some range of numbers of cells that they'll have in their body, and you'll notice it's a lot less than what we have. Some of our hair is involved in sexual signaling. So for example, facial hair, pubic hair, or axillary hair, all of those start to come in around the time of puberty. Your hair texture will sometimes change around the time of puberty, and in many people, it'll get a little thicker around that time, and those can help signal to potential future mates that you're of reproductive age. Those types of hair where it's thicker and coarser, and frankly you can see it at all, is called terminal hair. This is thicker and darker body hair. It's the hair on your head, your eyebrows, your eyelashes, your axillary hair, your facial hair, your pubic hair. It becomes thicker and darker due to sex hormones. Your head hair, in particular, still does have a protective element to it. Protects you against UV radiation, helps keep your head warm, helps protect your otherwise fairly thin scalp skin from abrasion. The purpose of your eyelashes and your eyebrows is to keep out debris from your eyes, and provide some mild amount of shielding from the sun. They're fairly small barriers, but they're better than nothing. Your eyelashes in particular are actually pretty good at catching debris before it comes into your eye, particularly since you have that reflex where you shut your eyes and withdraw a little bit when something's coming at your eyes. Your eyelashes can catch a lot of that for you. The hair follicle itself is an invagination of the epidermis into the dermis. So you have, here's your epidermis, and there's the boundary of the epidermis into the dermis. What you'll find is you have this big dent of your hair follicle, and that stratified squamous epithelium actually dips down and continues along the length of the hair follicle. Okay? The follicle itself, this whole invagination, is the part of the dermis that grows hair. And again, it's lined with the same type of stratified squamous tissue that you find on the surface of your skin. In the papillary layers where you find that oil gland and your erector pili muscle that helps stand the hair up on end and excrete oil onto the surface of the hair. And it's lined then in turn with what's called a glassy membrane, which is really just a connective tissue sheath, and an epithelial root sheath. So you have this connective tissue barrier. I'm going to pick a different color here so it stands out, green. Glassy membrane. It's called glassy membrane because of how it looks under a microscope. Remember, a lot of cellular stuff is named like that. So you have this like connective tissue girdle, and then everything in here is your epithelial root sheath. And you have the same layers of your epithelial root sheath that you have on the surface of your skin. You have a basal layer, you have a spinosum layer, and then you have this sort of keratinized layer closer to here, where you have sort of a corneum type of layers of skin. It's stratified like this the whole way around the hair follicle, except for the papilla. So you have this deep invagination of the hair follicle to the outside of the skin. Your papilla is down here, and it's a little bulb that contains a capillary bed, a really dense knot of capillary beds, and around that you only have a layer of simple squamous epithelium so that the nutrients and gases and stuff from the bloodstream can exchange with the cells immediately surrounding it. Okay, makes sense, right? You can't have a bunch of cell layers blocking off your nutrient source. You have to reduce that down into a simple arrangement. Here you can see there's the dermal papilla right here. And the rest of it, you can see there's this basal layer, and it just follows the whole way on down, right? It's the same type of tissue. The deepest down here you can see, you have a nerve plexus and a capillary plexus in there. This whole deeper end is called the hair bulb. And this again has, it's lined with simple squamous to allow for diffusion of nutrients and gases. This is just sort of a better overall diagram of the hair follicle with the stuff I was just talking about. Here you can see the sebaceous gland. Here's a better picture of where the erector pili would be. It's right up there adjacent to the sebaceous gland. And as these stratified squamous epithelial cells divide, they're going to lay down a layer of keratin onto the surface of the hair. Your hair is made up of very similar type of keratinized cells laid down like shingles as your skin, the outside surfaces of your skin. So here's another diagram of this. Your hair again is made up of dead flat keratinocytes. It is modified. It's very similar to the ones on the surface of your skin, but it is a little different. It's called hard keratin rather than soft, and it has to do with the molecular arrangement of the keratin a little bit and just how densely it gets packed down. The root down here is the portion that's being actively made. So you're making hair down here, which kind of makes sense because all these cells have proximity to your blood supply, right? And you're going to make them, and they're going to lay down these cells in layers. And as they work their way up, is how your hair grows, is when you have a layering from the bottom up that's pushing everything up and out through the skin. The part that sticks out from the bulb or the follicle is called the hair shaft. So down here is your hair root. The rest of it is the hair shaft. There's 3 layers to hair. There's a cuticle, the cortex, and the medulla. The medulla is a central core to the hair. It's basically a hollow, empty space, a hollow core. It might be fragmented where it kind of starts and stops. It may be continuous and just keep going the whole length. It may be entirely absent in some people. The cortex around it is made up of many layers of those flattened cells. It has humectant properties, so it absorbs and hangs on to a lot of moisture. The pigmentation to your hair is found at the deepest layers of the cortex right here along where the medulla is. Your cuticle is 1 cell layer thick of dead keratinized skin cells that are laid down in long, flat shingles along the length of your hair. The flatter and smoother they lay against one another, the less permeable they are to water. They also lay flatter against each other with acidity. So let's think about the implications of that, like the practical day-to-day implications of that. Think about when it gets humid outside, right? It gets hot, it gets humid. Heat is going to make so that these cuticle layers get pulled away from each other a little bit. The extra energy and the moisture in the air is going to pull those away. The cortex of your hair, with humectant properties, with moisture holding onto properties, is going to soak that right on in, and it's going to hang on to it, which is going to help force those shingles out even more to a point where you really realize it and you can feel the difference in the texture of your hair. This is what's making your hair frizzy when it gets humid out. Products that help keep your hair from getting frizzy generally add a coating to the outside of your hair to keep your cuticle from sticking out. Acidity is important when we think about shampoos and conditioners. Cleansing agents, detergents, shampoos, soaps are basic in nature at least a little bit. That's also going to blow out your cuticles. By providing a more pH balanced formulation that's closer to neutral, you can minimize that. And when you add conditioner to your hair after the fact, you can help offset that and make it so that your cuticles lay down flat next to one another again before you get out of the shower. Hair grows in 4 phases: anagen, catagen, telogen, and return to anagen, which doesn't seem like its own stage, but it is. Anagen is where you have active, rapid hair growth. This is where you're really actively growing your hair out of any given follicle. It grows at about a rate of 1 centimeter a month, give or take. Everyone's a little different, right? The catagen phase is where the hair production slows down. Anagen lasts about a month, maybe 40 days. Catagen's just a few days. Hair production slows down, and this bulb stops laying down new hair. The hair itself is growing more slowly. You perceive it to be growing more slowly at that follicle, not really because it's growing exactly, but because the end is starting to slowly work its way out of that dying follicle. The bulb has begun to deteriorate once it stops making new hair in the first place. The telogen phase, hair production has completely stopped. The follicle is completely deteriorated, and the hair is basically on its last legs on its way out. When you return to anagen, you're going to create a new follicle where the old one was. You keep making new hairs in the same places old ones were over and over and over your big fat asterisk here whole life. When your hair falls out, it's not so much that something is pulling your hair out as you're preventing this phase from kicking in as quickly as it ordinarily would. You're putting all of your hair through all of these phases and then just kind of stopping right about here. So your hair falls out and then it doesn't really seem to grow back. Cancer drugs are known for doing this. A lot of them, since they affect cellular turnover and they affect mitosis, that's going to have a big impact on what your epithelial cells can do. Your hair is laid down by epithelial cells. And so when you start inhibiting their growth, right, your follicle will grow hair. You start taking chemo, stops making hair. It seems fine for a while. That hair eventually works its way out. And in the meantime, you don't have any of your existing follicles going back to return to anagen stage. So you lose your hair for a time. People who experience like male pattern baldness, for example, they will just sort of have a more finite lifespan of any one of these follicular sites on their body, and that's genetically determined. The hair thickness can be due to a quantity of hair follicles overall, so how many hairs do you have is how thick your hair is, and also due to the thickness of the individual strands, the hair shaft itself. Curly hair is actually the result of 2 different things. One of it, which is disulfur bonds that can be created when you're laying down these cuticular layers of your hair shaft in the first place, but also because of the shape of the follicle itself. If you have a perfectly spherical round follicle, when you lay down new cells, you will lay them down at the same rate, basically the whole way around the circle, the same even distribution. When you have a more oval shape, you end up with an uneven, you see how it's denser at the ends? You have a more uneven deposition of those same cuticular layers of your hair. And when you have an uneven distribution like that, you end up making a curly kind of a shape. If you've got Play-Doh around and a Play-Doh extruder or something you can extrude Play-Doh through, I recommend you do this because it helps appreciate how that's actually growing out. If you have a perfectly circular shape and you push Play-Doh out of it, it's going to come out straight. If you flatten that out like a ribbon and you force it out with the same oomph as you did in the first place, it's going to twist up on itself a little bit because the different parts of the Play-Doh are along that length are going to get pushed out at basically a slightly different rate. And that's going to help cause different amounts of curliness or waviness. Chemotherapy, because you kill off that hair follicle and then you eventually, when you stop that chemotherapy, will regrow the hair follicles from scratch, may change your hair growth expression permanently. So people who used to have straight hair, maybe when the follicles grow back, they end up curly haired or vice versa or a different color. A lot of people will grow back gray. but that expression can change for the rest of your life. Nails, fingernails, toenails, are protective in nature. Their major function is protection and in aid of fine motor skills and digital manipulation. At one point in time, they were useful for self-protection, like in scratching and clawing, but our fingernails and toenails are generally weak enough that they don't do very well at that. They're analogous evolutionarily to hooves and made of the same stuff. So your hair is made up of this hard form of keratin, your nails are made up of that hard keratin, and so are hooves. Like cow's hooves are made up of the same stuff as your fingernails. The protective function of your fingernail or toenail is pretty obvious, right? Like it's this hard plate at the end of your fingers. Its aid in fine motor skills and digital manipulation is slightly less obvious. Think about when you pick up something small, like this person in the picture picking up a penny. And think about the tips of your thumb and forefinger, if you take a look at them right now. You look at where your nail is in relation to where you would pick that penny up with your fingers, right? You pick up the penny with the pads of your fingers, and the nails are on the opposite sides of your fingers from that. Your nails, therefore, serve basically as a backboard to your fingers, so that when you pinch down, now think about it, you have all this fat and skin and stuff surrounding the end of that bone there. The bone there is tiny. That's a lot of soft tissue around there. If you didn't have a solid backboard to your fingertips, when you pinch down on that penny, that tissue is just going to push back and out of the way, and you're not going to be able to grab the penny as firmly. By having that firm backboard, you can grip it much more securely than otherwise. For the same reason as having that backboard reason, you also enhance the sensation of the fingertip. There's more pressure on any given place on your finger when you have a firm backboard than when there's not. We're going to finish up with the anatomy of a nail. The nail is laid down very similarly to the hair. So you have a sort of a deep invagination of your epidermis. You have those very basal papillary layers that are secreting the nail, just like you're secreting the hair, and then they get pushed up and out. So the anatomy, you have the free edge of the nail, which is the whole part that's hanging off the end of the finger. The body of the nail is all the rest of it here that you can see. Okay, the pink part, if you look at your fingernails, there's the white edge and then there's the pink part. The pink part's what we're talking about. The little white half moon here that's part of your nail itself, that's not like skin or anything, that's called your lunelle. Okay, the nail bed is the epithelium under your fingernail, and that's helping to lay down new nail or to support the new nail that's being grown deep into your from your root of the nail. And you also have a bunch of skin around it that helps anchor the nail. So your nail isn't just growing up and out and is fairly loosey-goosey like a hair. It has other skin anchors, right? If you think about it, you can sort of appreciate that. Your skin comes around the sides. You've got this little flap that comes up around the lunelle, right? So you have a cuticle, an eponychium, and a hyponychium. The cuticle is one stratified squamous cell layer thick. You can't really see your actual cuticle very well. Sometimes you can feel it, and you can end up seeing that free edge by pushing down on it. Now, your eponychium is what you usually think of as a cuticle. It's that visible flap of skin that sits up at the base of your nail. The hyponychium is a similar type of flap that's on the underside of your nail, like right here, that attaches the underside of the nail to the skin. But take a look at your fingers and then slide your fingernail down the length of one of your fingernails towards the cuticle, and you'll see that there's a bit of a skin stop before you get to what looks like the cuticle, what you commonly call the cuticle. What you commonly call the cuticle is the eponychium. You notice when you hit that skin layer, before you get that far, that's properly your cuticle. That is really what your cuticle is. These three skin layers are very important in protecting the health of the nail. When fungus or bacteria works its way in and under, This is a beautiful, dark, warm, nutrient-rich place for microbes to grow. It's also a place where your blood supply isn't quite as abundant or quite as effective at bringing immune cells. So infections tend to hang on for a long time. It's really hard to get rid of fungal infections. Bacterial infections of the nail bed tend to come back over and over and over and over and over again. The single best thing that you can do to protect the health of your nail bed is to leave your cuticles, your hyponychium and your eponychium alone. Don't push back your cuticles. Don't let them cut your cuticles or your eponychium at the when you get a manicure or when you're doing your own nails. Sure, it looks nicer, but it's not going to look as nice if you end up getting an infection in your nail. And your hyponychium, you know how you have those little metal pieces or wooden pieces to clean from under your fingernails? Avoid those if you can. Use a nail brush instead, which is much gentler and will leave the hyponychium alone.